So switching gears a little bit to another data set that we saw, I'm going to ask Dr. Fidler to comment on this, and that's moving into what I like to call the 1% club. We've seen in adenocarcinoma of the lung a number of different genotypes that are potentially actionable this year. Well, not this year, we've heard about it before, but BRAF, and specifically the V600E mutation, occurs maybe 1 to 2% of adenocarcinomas of the lung. I think a year ago at ASCO, we saw the single agent dabrafenib data. And this year, Dr. Johnson presented the combination of dabrafenib, trametinib in this setting, so a BRAF and MEK inhibitor in this setting. You want to give us your thoughts about that?
Sure. So the one thing about BRAF, it is relatively uncommon, but it is one of the driver mutations that we see a little bit more where you have a patient with smoking history, which I think differentiates a little bit from some of these other driver mutations, which are not always, but almost exclusively never smokers. So there was preclinical data and also data in the melanoma world suggesting that it was rational to combine the dabrafenib and the trametinib in non-small cell lung cancer patients who had the BRAF mutation. And they only selected the BRAF, the V600E, which seems to be the one that really correlates with response to dabrafenib in lung cancer. So the earlier trial you mentioned was about 20 patients, small amount. There was a response rate, about 30% or so, and it did seem to be durable. So with the combination, the response rate was higher, and the durability was similar to some other driver targets that we see for other driver mutations. You have the dabrafenib, which is targeting the BRAF, and then the trametinib, which is targeting the MEK, which is a little bit downstream. So it's kind of a two-hit strategy, and it does seem to be working better for these BRAF patients. The patients who were exposed to these agents were more pre-treated, 1, 2, 3 therapies, and with BRAF being a worse prognosis, I just wonder if we'd see even better results if this combination was applied in the first-line setting.
And that's ongoing at this point, where the previously untreated patients are being treated with this combination. I don't know how many patients have been treated yet, but that's certainly attractiveness of that.
Does everyone test their patients for BRAF mutations?
We do, we have a set of kind of what we call actionable genotypes that we define as our initial thing before we kind of do the next gen sequencing. So we test for it. I don't know if other centers routinely test for it.
We have different levels of testing, but if you're going to do some sort of next-gen platform, it should certainly be one of the genes, whether you choose 100, 200, or 300. It's one of the top 10, so you definitely should do it.
But I don't always have my BRAF V600E back before I'm starting first-line therapy.
Right.
And I'm not always waiting for it in patients where it's 1%. And so while it's a compelling first-line idea, I think it may end up being a second-line strategy for patients where you're hunting for the genotype, and that takes some time.
It's hard to say, though, what's going to happen, and maybe even in the near future, because if you add up the cost of individual mutation tests, it's going to be more expensive than doing a next-gen it may be more expensive than doing a next-gen sequencing for all patients. So it could be that we'll have some of that data more upfront in the future.